recent clinical updates. This event has been carefully arranged by the Nordic AML Group's Educational Working Group, and the focus today will be on sharing the latest insights into the use of Aza-Ven in AML treatment, with a special emphasis on discussions from a Nordic perspective. We are excited to delve into the advancements and strategies that our esteemed speakers will present. First, we would like to extend our thanks to AbbVie for their kind sponsorship, making this session possible. Furthermore, technical support for the event is provided by the KG Jebsen Center for Myeloid Blood Cancer at the University of Bergen. Please, importantly, feel free to submit your questions via the Q&A feature throughout the webinar. We value your input, and your questions will help foster a more engaging and enriching discussion. Thank you again for being here, and now let me introduce our first speaker. Dr. Keith Pratt is an esteemed hematologist-oncologist from the Hospital of the University of Pennsylvania. Dr. Pratt is a nationally recognized expert in leukemia and has been at the forefront of groundbreaking clinical trials, particularly in the field of AML. His research on targeted therapies such as Venetoclax has significantly shaped current treatment approaches. We are fortunate to have him here today to share his insights on the use of Aza-Ven as a first-line treatment before allogeneic stem cell transplant. Dr. Pratt, the screen is yours. Now you're...
There we go. Maybe let's try this again. Thanks again, Dr. Albin, for joining me. I'm sorry I was on mute there, but it's a real honor to be part of this meeting. I'm looking forward to hearing from everyone on their use of Aza-Ven and hopefully having a dialogue on how we can do this better in the future. So these are my slides. So I think it's important to reflect on what we know about Aza-Ven as a frontline therapy for older adults with AML. We've updated the long-term follow-up from VIALE-A here in a manuscript published earlier this year. Median survival still ranging of 14.7 months for the Aza-Ven subset. The hazard ratio for outcomes favor the Ven arm, now down to 0.58, and a duration of remission of 18.2 months. There's some intriguing outcomes here, particularly longer-term outcomes that we could kind of dive into. But for the vast majority of patients, relapse will occur. So strategies to mitigate relapse with an allogeneic transplant in appropriate patients are important. One of the things that we bit struggled with at the beginning of understanding outcomes with Aza-Ven were how some of the classic markers used to guide us for risk stratification, how they applied to Aza-Ven treated patients. And what I show here is how ELN 2017-2022 risk stratifications don't do a very good job at discriminating remission rates with Aza-Ven, but scoring with 4 specific genes clearly they break down better the likelihood of achieving remission with 4 genes marking for outcomes. The low benefit group were the TP53 mutated subset, obviously very challenging to treat subset regardless of therapy. Those who had a TP53 had a 47% remission rate. Those who didn't have a TP53 but had a FLT3-ITD or K or an NRAS mutation had an intermediate benefit from Aza-Ven with remission rates of 59%. And everyone else fell into a higher benefit group. And of note, that's the largest subset of patients here, 145 out of 286 patients on study were in that higher benefit group. And as you might want to see, that the remission rates and the genes that predict them align with the survival. So those with TP53 had median survivals of 6 months or less. Those with FLT3-ITD or KRAS and NRAS had a median survival on range of about 12 months. And the other subsets were over 20 months of median survival. So it's important to keep that in mind when you're thinking about patients. I would also maybe caution against using this score in the way we use our typical ELN guidance in regards to stem cell transplants in frontline. But this will give some context to the outcomes in patients that are in front of you, particularly those patients that may be borderline transplant candidates. The urgency and clinical equipoise of a transplant or not in frontline can be kind of looked at in the context of these outcomes. Along the time we were doing the VALIA trial, we were also assessing minimal residual disease. This was done by a flow-based assay at a central lab. 41.8% of the patients at some point achieved MRD negativity if they had achieved a composite remission. In that subset that achieved an MRD response, the median survival was 34.2 months, whereas if you didn't achieve an MRD response, your median survival was 18.7 months on the Ven arm. What we also showed a few years ago in the MRD primary manuscript was the kinetics of this MRD clearance are slower than we might typically see. Conventional high-intensity chemotherapy, MRD response by end of cycle 2 seems to be an important marker for outcomes. But as you can see on the left here, that the MRD clearance by cycle in the VALIA trial was much longer through the treatment courses. In fact, about 52% of the patients achieved MRD response by end of cycle 4, but that meant 48% achieved it at some point later. And the remission duration, at least in this post hoc analysis, for those who achieved an MRD response by end of cycle 1, looked very similar to the MRD responding patients who achieved it after cycle 1. So I think it highlights the biologic heterogeneity of these patients, and perhaps the timing of response may not be as important as ultimately achieving it. And I think this becomes important when we think about how we apply Aza-Ven in the pre-transplant setting, and whether we really wait to someone achieving an MRD response, and whether that's important or not, I think is open for debate. And I have some data I'll show in a moment on that. Other intriguing data that I maybe highlight here more for use outside the transplant realm is the alignment of these responses, the high quality responses, MRD negative responses, seem to align with the likelihood of achieving full count recovery. And I wonder maybe out loud whether this is a reflection of deeper remissions with better counts later in the courses. Maybe something we'll learn in the future when we apply triplet therapies or better therapies achieving MRD early responses. So we did put together our prospective experience on the VALIA trial and the phase 1b Ven Dacogen trials in a presentation from EHA 2023. Basically, there were 31 patients on the frontline cohorts of the phase 1b dose escalation and expansion trials. And there were only 2 patients on the VALIA trial on the Ven arm who went to transplant. So total 33 patients that we have some prospective data on. And the response before transplants reflected here. Most of the folks were in a composite remission, 80%. 45% were in a complete CR with count recovery. The median time to transplant in this cohort was 5.9 months, or about 6 months. There were 2 patients who went to transplant that went in at MLFS and 2 patients who had refractory disease. And then there were 9 patients in the cohort of 33 who were in MRD negative remission. 16 patients were MRD positive at the time of transplant, and 8 patients who we didn't have MRD data at the time of transplant. These were the ages. Their median age group was 69 years old. Enriched for ELN adverse karyotype 60% of the patients there. There was a mix of other molecular markers, including 2 patients who were TP53 of the cohort. And the median survival post-transplants reflected here is 29.9 months in the cohort that we had. There were a few folks that hadn't gotten that far out yet. And in assessment outcomes based on MRD response on the left here, so as if you had an MRD response, the median survival had not been reached. The estimated survival at 24 months was 76%. That being said, if you hadn't had an MRD response or you were not accessible for an MRD response, the median survival still was 28.2 months in this older adult group of patients. And I think this aligns with what we often see with patients taken at this age to transplant after higher intensity treatments. We did break out the patients by ELN criteria on the right here. As you might expect, folks with a favorable ELN risk did the best. Intermediate and adverse marched out stepwise, as you might expect here, certainly with some of the adverse risk, TP53 subset probably being those of higher risk of relapse post-transplant. We also obviously weren't satisfied with that small number of patients. One of the fellows I work with, Andy Matthews, put this data together in 2021. It's published now on the real world outcome of patients given treatment older adults given treatment for AML. At least in the United States, and I think in many parts of the world, there are some alternatives for induction. This was a sub-study asking the question of whether the liposomal form of cytarabine daunorubicin, CPX351, was led to a different outcome than patients given Aza-Ven. Similar trial populations included in this analysis. We went to the real-world database in the United States, which in Canada that takes EMR data and allows it to be shared in a de-identified way to ask questions that might not be answerable with current literature. This was a group of patients 18 and older, newly diagnosed AML, no prior therapies before, and overall survival is the primary endpoint. And our hypothesis was the assumption that the CPX351 would improve overall survival. But we ended up finding was the outcomes look very similar regardless of what backbone therapy you initiated at time of initial treatment. This data consisted of outcomes generated from 439 patients given Aza-Ven and 217 patients given CPX351. These Ven-Aza patients were older on average, 75 versus 67. Similar in many other respects. There were some slight differences in how their types and academic practices were labeled in the data set, but by and large, a very similar group of patients. And what I think is important when you look at this data to assess the outcomes here is that the leading outcome really is only when you pursue a transplant after one of these 2 therapies. Obviously, a lot of selection bias to patients who are fit enough and well enough to do a transplant, but specific therapy before transplant didn't seem to lead to any different outcomes. And the median survival after transplant looks similar or doesn't look inferior on the Ven-Aza arm. We had some other data that was looked at here. Early mortality, 30 and 60 days, looks very similar. Likelihood of infection was slightly less on the Ven-Aza arm. Not sure where the red dot comes from. Sorry about that. And then also looked at likelihood of febrile neutropenia, which was higher in the Ven, higher in the CPX arm, likelihood of positive infection, and mean hospital days were higher in the Ven or in the CPX arm, and lower in the Ven-Aza arm. There have been several other data sets published over the past few years looking at different therapies prior to stem cell transplant. These are data out of University of Colorado, again, assessing HMA-Ven or Azacitidine-Ven in this case, compared to conventional chemotherapy induction. It doesn't appear that there's a higher rate of relapse or inferior overall survival by Ven-Aza in the patients who were transplanted afterwards. And then this manuscript was just published this week, looking at a larger data set, given Ven and decitabine as a bridge to stem cell transplant. These are patients aged 60 to 75 who had either intermediate or high risk AML by 2017 ELN. They gave standard decitabine, which was given for 5 days, and a typical venetoclax dose ramp up, and treatments of 28 days length. 93 patients were treated in this manuscript, 69 of which achieved a composite CR. And of the 64, 53 went to transplant, which was 83% of the responding patients. And again, overall survival, non-relapse mortality, and cumulative incidence of relapse here look very much appropriate with what we would see typically after higher intensity treatments before transplant, in my opinion. And I think this raises the question, should this be one of the frontline strategies for patients before transplant? The other challenging place we're at right now with some of our criteria for labeling myeloid disease is this newer WHO overlap syndrome of greater than 10% blasts called MDS-AML. I think it's important to start looking at this overlap data. These are data from Dr. Garcia-Manero presented on patients with high-risk MDS. These are patients with greater than 10% blasts who were treated in one of the frontline trials of Ven-Aza. Composite remission rates very similar to what we saw with the acute leukemias who went to transplant. Importantly, with the lower blast percentage, they were only giving 14 days of venetoclax per cycle. Median age group of the patients who proceeded to transplant in this data set was 64. As you might expect, a number of high-risk molecular features, including a large number of patients with TP53 in this data set. And the median overall survival had not been reached in this data set so far. 24-month estimated survival was 71 months for those who achieved a composite CR before transplant. So in conclusion, HMA-Ven achieves remissions at rates in many respects comparable with conventional chemotherapy. I think the perspective and the real-world data suggest comparable outcomes with induction and in some respects lower degrees of hospitalization and infections. Future randomized data will really be able to answer the question, what's the best strategy for some of these patients? And those trials are enrolling at this point. I point out some of the molecular markers here. Some, I would argue, probably have some more questions to be asked and answered in regards to the best frontline therapy. And of note, the ones that I have the most concerns about right now are the RAS mutant leukemias and FLT3 mutant leukemias that I have intermediate benefit for Ven-Aza, and whether there's a better strategy with cytarabine-based chemotherapy, I think we have to answer in the future. But if I can answer any questions either on this forum or by email, please reach out. And again, thank you for the organizers for inviting me.
Thank you very much, Dr. Pratt, for this interesting presentation and presenting this interesting data. Um, I again urge the attendees to post questions in the Q&A function. While they're thinking, I can perhaps start. You alluded to it in the beginning and in the end. I mean, what all clinicians long for are specific genetic or molecular markers that would identify which patients would benefit most from Aza-Ven as a first-line treatment before allo. I mean, can you comment or elaborate on the usefulness of, for example, this FLT3-ITD, RAS mutations, and P53 as prognostic markers, or what patients, in your opinion, should perhaps be given intensive chemo regimens plus venetoclax as compared to Aza-Ven? Any comments, please?
Yeah, it's a great question. I think if you know the patient has a RAS mutation, I think those are the patients that we probably would be leaning towards a cytarabine-based combination, either with venetoclax or without venetoclax. It's interesting in historical data sets, RAS wasn't quite as bad a predictor in regards to outcomes with classic chemotherapy. So leaning on that data, I would argue that's the group of patients. The CMMOLs with RAS backgrounds, I think, are the obvious ones that probably should be considered as a cytarabine-driven chemotherapy regimen. The FLT3 patients achieve remissions at similar rates to those that we see with high-intensity treatments. The relapses just occur earlier, and I think there are triplets data out there. There's use in my practice of a FLT3 inhibitor after you've gotten a remission with HMA-Ven while you're bridging them to transplant. I do fairly routinely. And obviously, we use FLT3 inhibitors post-transplant to mitigate that relapse risk. So it's the RAS patients in particular right now that I have concerns about. And then you asked about the TP53 subset. I don't know of a better solution. And I think that the toxicity is less with the HMA-Ven. Remission rates seem to be very similar. If you can get that patient to transplant quickly, the outcomes look okay. So I still use Aza-Ven for the transplant-eligible TP53s.
Mm-hmm. 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 Okay. Another question here is what's the ideal duration of Aza-Ven treatment before allo? I mean, you showed the cumulative incidence there reaching 100%. What's your take on that?
Practically, I like to give patients 3 cycles and then transplant them. I think that aligns with the time it takes us to get a donor and a transplant organized. I get a bone marrow assessment after cycle 1. If they're in remission, I'll give them cycle 2. Plan the dates of the transplant after, cycle 3, when you would typically give cycle 4. I don't use MRD at that point to guide the timing of the transplant. I think that's a question that comes up a bit. Should you wait for an MRD response to transplant them? Even if you're using a low intensity approach, I don't know that we have data with this treatment that the MRD status matters so much for transplant outcomes. So that's my approach.
Mm. And if in case you don't reach remission, or if you see that the remission is not deep enough, do you use chemo then as a bridge, or instead of Aza-Ven? Do you change or?
I think you can. I think I always give 2 cycles of HMA-Ven, to give a fair opportunity to get a remission. If after cycle 2 the blast numbers are going up or they're really not responding, then I'll have a discussion about, cytarabine, high-dose ARC-based chemotherapy as a bridge to transplant. Really, it's patient-specific. And obviously, if there's a targetable lesion that you can add a drug to the mix, that's where I use the FLT3 inhibitors, the IDH inhibitors, those types of things. So.
Mm-hmm. Okay. And with your experience, how should treatment be timed in relation to preparation for allo? For example, then stopping treatment prior to conditioning.
That's a good question. So I time allo prep usually on the 4th or 5th week after HMA-Ven. And I stop. I didn't show this data today, but I once patients get remission, I almost only ever give 21 days of Ven, so they're off Ven for a week to 10 to 14 days before they get admitted to the hospital. I think that it is important to go to transplant with some degree of neutrophils, and I don't like patients going to transplant ANC of 0, never recovered. I didn't share data today, but we're going to publish in manuscript form shortly the use of growth factors after achievement of blast clearance as a way to get neutrophils up. I think that's important for TRM after transplant.
Yeah, I was just going to ask that. How do you, what mitigation strategies do you use to manage cytopenias before allo to ensure the patients remain eligible?
Yeah, it's growth factors. It's after the patient's blasts are cleared, and usually after they've finished 21 days of venetoclax, maybe 14 in some patients. There's a group of patients who are really aplastic. Their bone marrows are empty after 1 or 2 cycles of HMA-Ven. And I will often lower the azacitidine dose to 25 milligrams per meter squared in those patients to allow the hematopoiesis to reset up. I find that's very helpful. And obviously, you need breaks between cycles. Very few patients stay on a 4-week cycle length. Most of my patients are on a 5 or 6-week cycle length with HMA-Ven now.
Mm-hmm. And then touching upon the post-transplant setting a bit, have you seen any increased risks of any transplant-related complications in patients receiving Aza-Ven before allo compared to conventional chemo?
I have not. Anecdotally, I think my patients do better with early mortality after Aza-Ven post-transplant. I wish I had more specific data to say that's true. The paper that I showed towards the end there had some TRM data, GVHD data. It looks very good. Interestingly enough, this is similar to what the CPX versus 7 and 3 data set showed, which was the relapse rates were the same for patients who went to transplant after 7 and 3 or CPX 351. But the TRM, the treatment-related mortality or transplant-related mortality, was significantly lower with CPX 351 than 7 and 3. And I think some of that is because patients went in with less infections and less end organ failure and led to better outcomes. So I think that's the same message I see with HMA-Ven.
Okay. Thank you very much for these insights. We've had 2 questions in the Q&A. There was something about MRD negativity. I think you touched upon that already, unless you want to comment further.
Yeah, I think this is a good question. I know of all the MRD negativity and obviously in patients who are getting high intensity treatments that predicts for outcomes better with a RIC transplant. But I don't know of any data other than the data I just showed you that MRD remissions really are predictive for Aza-Ven before transplant for RIC transplant. I think if they're eligible, they're in a morphologic remission, they should go because that's their one chance at cure often. And then the doses of Ven, HMA-Ven, I use 400 milligrams without an azole, and I use 50 milligrams with posaconazole or voriconazole. I think duration 21 days after remission in my standard practice.
Great. Thank you very much. I think it's time to move on with the case presentations that we've selected. These cases are to be presented by 2 of my colleagues in the educational working group, Nils Morten Leknes at the University Hospital of North Norway and Christer Nilsson, Karolinska University Hospital, Stockholm. Let's start with Nils' case here. Nils, go ahead.
Yeah, this first case raises the question of relapse treatment one should choose. And this is a 57-year-old man, colorectal cancer in 2015, and needed neoadjuvant chemotherapy and radiation therapy. and was also given surgery treatment and was assumed cured. And he also had some problems post-surgery with small bowel obstruction in 2022, treated with surgery. And then it was diagnosed in AML, favorable risk in 2023 with a B allelic CBP alpha BCIP domain mutation with also 2 TET2 mutations, while the karyotype was normal. And he received the standard HOVON treatment with 2 induction courses with 3+7 and the next 3+6. And he was MRD negative, had an MRD negative CR after the 2 induction courses, and he was treated with autologous stem cell transplant. He had some complications with a CVC infection with quite substantive septic pulmonary emboli 1 month after end of treatment. And 8th month after end of treatment, there was found a MRD relapse in his bone marrow, 0.8%, and 2 weeks later, while he was evaluated for start of treatment, he also was in morphologic relapse. And a repeated diagnostic workup revealed a new pathologic DNMT3A mutation, while the other mutation was also found now, while the karyotype was still normal. And he was regarded as a high-risk patient with a HCTCI score of 5 points. And the question is, what is the ideal treatment for him as a bridge to allogenic transplant?
Yes, thank you, Niels, for this case presentation. I don't know, Anne-Louise or Keith, if you want to just briefly comment or give your views on this case, and perhaps the question on the lower part of the screen. What alternatives do we have for this patient? Is Aza-Ven first option, or what do you think?
I think Aza-Ven could be a good option for this patient. We know from retrospective data that it also works fine in the relapse refractory setting. And also he has received chemotherapy prior, both for induction therapy, but also for his colorectal cancer. So probably good to go with a semi-intensive treatment with lower toxicity and get him into transplant in a better condition, perhaps. So I think that would also be my first option. And probably since he do not have a full-blown relapse, he could manage without too much cytopenia.
Yeah, I would agree. I think in this situation, this patient's been through a lot of therapy and high intensity treatments twice, and BCI auto probably would be a challenging patient to successfully go through an allo. So anything that we could do before this allo to mitigate toxicity would be beneficial. And HMA-Ven is still probably most likely therapy to get him to transplant safely. I'll make one comment about the DMT3A mutations. Hartman Donors publication in Blood this past month looked at all the molecular subsets, and the specific DMT3A mutations pull into the really most beneficial or most durable remission group of HMA-Ven. They had a median survival of about 40 months. This is obviously a relapsed one, so take that for what it's worth. But I think this is a very sensitive HMA-Ven patient, so I would typically choose that for this patient.
Thank you. Perhaps we can come back to these cases in the end of the webinar if we have time, but let's take Christer's case. Go ahead.
Yes, so this second case brings us to the topic of dose optimizations of Aza-Ven. In this case, we have an 84-year-old female with aortic stenosis, Alzheimer's disease, and anxiety. She lives by herself, but she has good support from her daughter. And she presents with shortness of breath and dizziness. In the blood chemistry, there's pancytopenia, and a bone marrow aspirate confirms acute myeloid leukemia with 64% blasts. She has apparent memory problems, and there's an in-depth discussion with the patient and family on treatment or not, but there is a decision to treat, and she's given a mild induction with azacitidine 100 milligrams per square meter for 5 days, which is standard in Sweden, together with Venetoclax 400 milligrams for only 5 days. And this brings her into complete remission. And later, the genetic workup shows trisomy 13 and mutations in B-core, RANKS1, and SRSF2. Which makes her adverse risk according to ELN 2022. So in her second course, there is a dose adjustment. She's given azacitidine 100 milligram flat for 5 days, together with Venetoclax for 7 days. And in subsequent cycles, she is given the same lower azacitidine dose and only 200 milligrams of Venetoclax for 7 days. And these subsequent cycles are given in 35 to 42-day cycles. And this is very well tolerated with only mild cytopenias and no infections whatsoever. And so this is kind of a lower intensity Aza-Ven treatment. And what are the reasonable dose adjustments, especially in this frail patient population?
That's a very good question. And Ann-Louise will go into detail in her talk just in a brief moment. I don't know if the panelists want to add or comment something at this moment.
I suspect this will be going on over in the next talk, but the French group, Stéphane Baton, presented the 7 days of Ven with 7 days of Aza data. The remission rates look the same. The durability is a little bit challenging to interpret because the patients were sicker than the VALIA patients. But I think in an 84-year-old, you use what you can tolerate, and this is very appropriate dose adjustments in my mind. I think the unanswered question is 7 days of Ven or 14 days or 21 days is the optimal dose. I don't think we know that. There was a manuscript of flat Aza 100 milligrams and 100 milligrams of Ven that came out a few weeks ago, looking very promising, kind of continuous dosing with very little cytopenias. So it's an unanswered question what the appropriate best dose is, in my opinion.
Yeah, so I agree with the dosing. A good idea to go with the low dose that keeps her out of cytopenia without infections. And then another point is she has Alzheimer's disease, memory problems. So we also, of course, have to think of for whom are we treating, and keep on asking ourselves as we go along, what are the side effects of the treatment and what is the purpose of it. And yeah, but of course, the treating physician knows her well, I suppose.
Yes, thank you. Let's delve into those optimizations. As Ann-Louise Tølbøl Sørensen, clinician and researcher at Rigshospitalet in Copenhagen, will share her expertise on key considerations for determining when, who, and how to adjust dosing to improve patient outcomes. Please go ahead.
Yes, so thank you, Albin. So I'll talk about dose optimization of Venetoclax azacitidine and what we know about how we do this in the best way. But before addressing the when, how, and who questions, sorry, just need to. I'll start out with a why, and These data are familiar to all of you. The pivotal VIALE-A trial demonstrating superior efficacy of the combination therapy with venetoclax azacitidine with a median overall survival of 14.7 months as compared to 9.6 months for azacitidine monotherapy. But we know that it comes at a price. There's a high degree of hematological toxicity, primarily grade 3 and higher, thrombocytopenia, neutropenia, and febrile neutropenia, which gives a higher risk of severe infections and prolonged hospitalization. Sorry, just I think it's the next one. Yeah, so we need to dose optimize, and how do we do that in the best way? So do we wait until the patient is in remission before we start modification of the regime, or should we do that already upfront? Should we modify the dosing schedule with prolonged cycle intervals? Should we modify venetoclax dose, both dose duration and venetoclax dose, and also azacitidine dosing? And what about the patient? Should we do it equally for all patients, or should we modify depending on which subgroup of patients we're treating? So first, I'll just have a quick look at the learnings from the VIALE-A trial, which has sort of laid the foundation for how we do dose modification in the clinic. So the standard dose in the trial was venetoclax ramp up and then 400 milligram from day 1 to 28, so a full circle, plus azacitidine 75 milligram per square meter for 7 days in 28-day cycles. Dose adjustments were allowed when morphological remission had been achieved. And in VIALE-A, that occurred fast. The median time to first response was 1.2 months, and the median time to the best response was 2.1 months. So we need an early response assessment by a bone marrow, usually taking at the end of cycle 1 to assess whether persistent cytopenia is due to disease or to treatment toxicity. And in the VIALE-A trial, there was a stepwise guidance as of how to dose modify. So first it was to delay the next upcoming cycle. Second, to reduce Ven duration. And if those modifications still give rise to persistent cytopenia, then azacitidine dose could be reduced. And Dr. Pratt is here with us today, and he published this study, which was a post hoc analysis of how cytopenia was managed in VIALE-A and how it related to the outcomes. And it showed that the vast majority of the population had hematological toxicity that required dose modifications. So this is looking only at the responder population. And for those who had at least 6 cycles of treatment, 76% had reduced Ven duration and a median cycle time of 34 days. And what the study also showed was that venetoclax duration or shortening of that, it did not impact overall survival, whether it occurred right after remission or later on in the cycle. G-CSF was used to help recovery from neutropenia and to shorten the duration, and half of the patient received that. And importantly, that did not affect overall survival, as shown on the right-hand side curve, where the plus G-CSF is the darker blue curve and the without G-CSF is the lighter blue. So that can be used when patients are in remission and then stop before initiation of the next cycle. As also alluded to, we of course have to reduce Ven dosing according to concomitant CYP3A4 inhibitor medication used, which is typically fungal prophylaxis. And one important point here, is also mentioned by Dr. Pratt, is that if patients have persistent cytopenia, remember to reduce venetoclax even further. It is actually shown that venetoclax 50 milligrams plus posaconazole best reflects the same plasma concentration as venetoclax 400 milligram without any concomitant azole. And then turning to the real-world data, what do we know about a modification of Ven-HMA treatment, and how do we do it best, and how does it affect efficacy outcomes? So we don't have any prospective studies yet on the dose optimization, and we'll therefore look at the retrospective data while we're all waiting for our Nordic LD-Venetoclax trial to complete. And there are several retrospective studies published by now, and I'll go through a few of them. And one thing I think it's important to consider when we're looking at the data is that there is a degree of selection bias, as we have a tendency to dose reduce those patients which fare best and are in a good remission. So they will be enriched in the dose reduced cohorts. And another thing before looking at the retrospective studies is that when we look at efficacy, then the real-world data does not reflect completely what was found in the VIALE-A trial. Here is a meta-analysis of pooled Ven-HMA studies in first-line treatment, and they show a median overall survival of 9.4 months. But of course, the studies varies a lot. So the first study is an American study by Boyce Clare and colleagues, a single-center retrospective study that looked at post-induction Ven-HMA modification. And by post-induction, they mean from cycle 3 and beyond. They looked at 142 AML patients, both de novo and relapse refractory, and on how dose was modified. So the data here are only showing for the patients that actually completed 3 cycles of treatment, and that was a little more than half of the patients. And those patients were divided into groups depending on the median days between the cycles, so either 34 days or below or 35 days and above, and according to the median Venetoclax dosing days per cycle, either 14 days or less or 15 days and more per cycle. And when looking at the overall survival curves, we can see that prolongation of the cycle interval to 34 days or more did not impact overall survival. But when looking at Venetoclax dosing, a shorter dose duration was actually associated with an improved overall survival. And in multivariate analysis, they also found that shorter Ven duration was a predictor of decreased mortality. And then the authors speculate that perhaps the lower Ven exposure may reduce the required resistance that is often a problem during Venetoclax treatment. So another study which also addressed the WHO questions, it's a study conducted in octogenarians and nonagenarians, so the very elderly population. It's a US-Italian study which included 154 patients across 6 institutions, AML patients, both de novo and relapse, with a median age of 82 years. So 67% of the patients received full dose Venetoclax in the first cycles, and of those, 72 were reduced with regards to Venetoclax dose or duration in the subsequent cycles, and may also have had prolonged cycle intervals. And then 23% had reduced Venetoclax already in the first cycle with a median of 14 days of Venetoclax. And half of the patient had also a reduction in the HMA dose. For the whole population, Venetoclax was given at a median dose of 400 milligrams for 14 days on a 35-day cycles. And for the patients who were in remission, it was even further reduced to a median of 200 milligrams for 14 days, again on a 34-day cycle. Then they did a multivariate analysis to see how shortened duration of Venetoclax influenced overall survival. And here they could show that shorter Ven duration was associated with an improved overall survival. And then to try to compensate for the selection bias in that patients which are in a good remission probably are grouped into the shorter duration, they did a landmark analysis from the time of CRC achievement, and here shorter Ven duration remained associated with improved survival. What about Ven dose during the first cycle? Can we also reduce already at initiation of the treatment? Here there are, of course, fewer patients in the shorter duration Ven curve shown in blue, but that did not affect overall survival. And when breaking up the data into further groups of Venetoclax 7 8, 14, 21 days, we can see that numerically the shorter Ven duration did as good as longer Ven duration, except for perhaps the 7 days or lower treatment, which probably reflects early death due to disease progression, perhaps also sepsis. So another study looking at shortened Ven duration is a retrospective study from a single center, including 176 patients, again, both de novo and relapse refractory. And here the patients were grouped according to median day of 14 Venetoclax per cycle versus 28 days of Venetoclax. And they could show that both in the frontline setting and in the relapse refractory patients, there was an improved overall survival with shortened Venetoclax to a median of 14 days. And also that during the maintenance phase, they could show that this resulted in a lower incidence of neutropenia, thrombocytopenia, neutropenic fever, and also reduced hospitalizations due to neutropenic fever, which was 40 compared to 20. And then also, as mentioned by Dr. Prats, one of the first studies that came out looking at dose reduction was the French 7+7 study, where they included 82 de novo treated AML patients. And here they could see that if they matched the eligibility criteria to correspond to what was included in the VIALE-A trial, they had a similar median overall survival of 13.8 months. Whereas the red curve is showing the whole population with more comorbidity than what was included in the VIALE-A trial. And also of interest, the responder population actually had further dose reduction later on for many of them. Yeah, and then just another smaller Chinese study where they had 36 patients reduced Venetoclax to 100 milligrams without ACEL treatment for 14 days, standard Azacitidine. They showed a median overall survival of 17 months. But here the patients were almost all of them de novo AML. And also a lower incidence of grade 3 infections with a lower dose Venetoclax. So when addressing the when and how question, I think that from Ven dosing modification, we can conclude that Ven duration should be shortened when remission is achieved. Most often that is done with a shortening of 7 days. And the question is then, how should we start out? I think some of these studies, even though they're retrospective and with the selection bias, we can say that at least for some patients, it's safe to start Ven dose reduction already from the induction. And the question is whether we should start out with 7, 14, and 21 days, and also reduce to that during the maintenance phase. And then, of course, remember to adjust Ven dose strength according to concomitant CYP3A4 inhibitors, and perhaps reduce even further to 50 milligrams if posaconazole is used. Ven dose modification should be used in combination with a delayment of the next treatment cycle. The retrospective data also show that it's safe to prolong the treatment cycle with up to 14 days, perhaps even further for the patients who remain in deep cytopenia, and that G-CSF can be used post-remission. And finally, Aza dosing modification, that's usually done later on if there's persistent cytopenia despite reduction in the Ven duration and prolonged cycle intervals. They usually would you reduce to half or 1/3 of the dose, depending on the bone marrow cellularity. And then I think for us in the Nordic countries, we perhaps also tend to reduce according to our Nordic azacitidine dosing schedule, where we dose for 5 days. So here giving 5 milligrams per square meter instead of 100. And despite all these dose modifications, we still may encounter a situation where count recovery is not always possible. And at those situations, I think we have to consider how good the remission is of the patient. And if the patients do not have any symptoms, and if it's safe otherwise, then continued therapy. Could also consider to give Aza monotherapy at least for 1 cycle. And finally, if the patients are in a good MRD negative remission, consider even to cease therapy. And then finally, for the WHO question, the studies mentioned also touch upon those. I think that the learnings from Viala A show that at least with time and the cumulative toxicity with the treatment, eventually all patients would have to have dose modification in one or the other way, or combinations hereof. One of the studies looking into patients that were 80 to 90 years old showed that dose reduction in vein duration and prolonged cycle interval is safe. One of the studies, the study by Bolini, also looked at comorbidity and found that dose reduction can be done safely in those patients. And I think in general, we just have to look at the patient and dose reduce if they are faring well and they're in a good remission. We also need to consider the treatment line, as also mentioned in the case we discussed. If the patient had been through a lot of treatment prior to Veneza, especially also coming from an allogeneic transplantation, we probably need to dose reduce early on and also have a look at the azacitidine dosing and reduce that one perhaps even upfront. The AML subgroup and the mutational status also influence how we dose reduce. I think we all know that the patients with myelodysplasia-related changes or prior MDS, they tend to have prolonged cytopenia. And in the less small study, they could also show that that population was enriched in both the group with a shorter duration of VEN and longer treatment cycles. And finally, also consider the risk group of the patient, the ELN risk category, or the DONA 5-gene signature score that Dr. Prats alluded to, and perhaps dose modify if we can see that they're in a good remission. And also look at the MRD response and even consider perhaps stopping therapy and following the MRD response. Finally, I just want to mention our common prospective Nordic LD-Venetoclax trial, where we look at dose reduction from the first cycle. We give 14 days of Venetoclax until the patient is in remission, and then we reduce to 7 days of Venetoclax. And thank you to all of you for including in the trial. We're doing really good, and hope to be able to present some of the first result next spring. And one thing that we could discuss also in the future is now we're talking about dose modification of Venetoclax azacitidine. How do you do it the best way? What about MRD-guided treatment decisions? Perhaps include that in a adaptive platform trial looking at these data. Yeah, so that was the end for the dose optimization of why, when, how, and who, and maybe also for how long.
Thank you very much, Dr. Tellberg Sørensen, for this extensive presentation on dosing optimizations, and looking very much forward to the first results of the LD-Venetoclax trial next spring then, hopefully. I again remind the attendees to post questions in the Q&A function. We haven't had any questions yet, so I can perhaps start. You on your last slide there, you had a little bit of biomarkers. In your opinion, I mean, we don't have biomarkers today to really find dosing optimizations. But are there clinical tools or other tools that one can use to dose optimize?
Yeah, well, so of course you can do a geriatric score to look at frailty before you start treating the patients. We are not using that systematically here, more having like a general consideration of the patient and comorbidities before we start treatment. And then, of course, we also look at the genetics before starting treatment. In the trial, we're looking into whether we can do drug screening and resistant testing to see upfront whether you can predict who will respond to therapy and who will not respond to therapy, but that is still research ongoing.
Another perhaps thought-provoking question would be that do you need the combination of Aza-Ven in all cycles? Or would it be perhaps reasonable to take one cycle of Aza-Ven and then take one cycle of perhaps Ven or Aza, just to get rid of these cytopenias, long-term cytopenias, for example?
I think that's a great question. At least we find that with continued dosing, you will have prolonged cytopenia. But we also know that the treatment works best if you give it together. So there's a synergy. The trials on Venetoclax monotherapy didn't show much benefit. So what we do usually is that if you have prolonged cytopenia despite dose modifications, we tend to give azacitidine monotherapy, perhaps even in combination with reduced azacitidine. Yeah.
Yeah, perfect. Just in the interest of time, I think we take the question here in the Q&A and then we move on. So the question is, how would you treat your IDH1 mutated patients ineligible for intensive chemo today?
So we would still give them. We don't have any access to IDH inhibitors yet in Denmark. For that reason, we would still give Aza-Ven. So I think there's data on that. If you have ivosidenib, then it's probably best to start out with the Aza-Ivo, and then if that fails, then you turn to Aza-Ven. But I think there's a prospective trial also set up to address that question.
Seems like Keith would like to say something.
Yeah, no, I was just going to mention, I think it's a great question. We have both in the United States, and I still tend to favor Aza-Ven frontline. There's data in Hartman's paper on genetics that really highlight the co-mutation beyond IDH1. In particular, the patients with IDH1 and FLT3 or IDH1 and RAS mutations really having a challenging overall survival. So I think we need to look at that data set, particularly the Agile data set, more closely for co-mutations and see whether that held true for that data set. But nonetheless, I tend to use HMA-Ven, not waiting for IDH status. And then if they're really struggling for cytopenias, I'll move them over to the IDH inhibitor Aza.
Thank you. Now, our final speaker for today is Dr. Martin Gädersten, a hematologist and researcher from the Karolinska Institute in Stockholm. He works mainly on myeloid blood disorders, and today he will delve into how Aza-Ven can be utilized for maintenance therapy. Martin, go ahead.
Thank you so much, Albin, and thank you for the invitation to speak today. Just gonna see which screen I'm sharing. I can't actually see which one I'm sharing, but do you see the presentation mode? Or?
Yeah, it's the right one.
Okay, great. All right. So given the previous talks, there may be a little bit of overlap, but I think that there are some new aspects that we could discuss here. And just adding on Anne-Louise's talks about the issue of the cytopenias, I would like to present shortly a case here of a 79-year-old man with AML-MPN1 who was treated within the LDVNX trial, and he received the standard treatment initially, and he had an excellent genetic response. Due to cytopenias, we performed a full new panel, and as you can see, his 5 mutations had gone down either to something resembling perhaps even a chip with DNMT3A, and the others were non-detectable by this analysis. But he did have significant cytopenias, and he had marrow hypoplasia. And can see he required long pauses, sort of borderline to be able to be kept on the trial. And this summer he received 2 cycles of single azacitidine that resulted in marginally less cytopenias. And as you can see, he's still actually transfusion dependent for his hemoglobin, and his platelets and neutrophils are low. So he's not really tolerating this. And what we did now is that we put him on Eltromba bag, and we gave him now, we will actually stop treatment now for 2 to 3 months and observe. And I will communicate with Anne-Louise, but probably we need to take him off trial. He doesn't tolerate this combination. And just looking to this picture, just as a conceptual way of seeing this, that if you have severe cytopenias, it can at times reflect deep cytogenetic responses. My patients that I alluded to was an NPM1 mutated patient that generally tend to respond well, as we all know. This case, I just picked it at random because it was a nice plot. And this patient, as you can see, actually had 5 different mutations, including clear MDS like SRSF2 and ASXL1. But still, on Aza-Ven, the patient was able to receive a very, very deep remission. So even in these cases, at times they respond beautifully well. So, and then again, just conceptually, since I found this nice graph, at times when we reevaluate a full myeloid panel, we just see that there is nothing happening. The VAFs might be exactly the same. We might have been able to push down 1 or 2 subclones, but others that are clearly more of high risk MDS-like persist. And at the times, the patient might be hyponormo or hyperblastic in the marrow, but still I would say it reflects simply a poor genetic response. And this may also result in cytopenias. And Dr. Prats alluded to the concentrations of both drugs and said that he sometimes goes down to azacitidine even 25 milligrams per square meter. And Anne-Louise also talked about that. And I think, of course, this is generally based on clinical experience from handling a lot of these patients. There's not so much data, to my knowledge, functionally to suggest which dose to use in a particular patient. I think this somewhat old paper now is at least conceptually interesting, where they looked ex vivo at healthy cells and MDS and AML cells. And they found that at a certain somewhat higher concentration of azacitidine and ven, you kill off the healthy cells. Whereas if you give a somewhat lower dose, you can actually find some therapeutic window where the healthy cells are preserved, but you kill off the malignant cells. And obviously, we don't know for the particular patient which doses they reach, and we don't know the individual sensitivity to their clones. But conceptually, there may be, it might be possible to, in a certain patient, find a balance here. Moving forward on that, I just quickly added now, actually, I had not seen that publication, but I believe this might be the publication that Dr. Prats alluded to that was recently published in August, using a fixed low dose of both azacitidine and ven in elderly unfit AML. And here they used this 100 milligram flat dose for 7 days and a low dose ven of 100 milligrams for 28 days. And as you can see, the CR/CRI is relatively impressive. It's approaching VIALE-A data, and also the outcome seems decent. Of course, this cannot be recommended at present, but it shows that even lower doses can actually be efficient. Whether this reflects lower degree of cytopenias, shorter time between cycles. Maybe you are able to keep the 28-day cycles. I need to look into the details of that study, but theoretically, I think it's conceptually interesting, and it was very well tolerated. Another way of trying to circumvent the problem with cytopenias in extremely frail patients might be to use this metronomic concept that has been pursued by doctors at the Cleveland Clinic, and they initially published this data on MDS in second-line therapy, and they gave decitabine at very low doses with the aim of inhibiting DNMT1. And as you know, when people in the 80s started to use decitabine and azacitidine, they used much higher doses and got a lot more cytotoxicity and so on. But to get the hypomethylating effect, and you can actually go down substantially in dose. And in this second-line therapy, they had 16% CR and 28% hematological improvement, which is relatively impressive for single agent decitabine in this setting. Moving on from that, the Cleveland group again looked retrospectively at 39 patients with MDS or AML that received low-dose decitabine plus venetoclax, and then they used this weekly dosing of this extremely low-dose decitabine, and then they pre-treated with venetoclax the day before to get the synergy and also to prime the mitochondria. They had a theory based on an abstract, I believe. And anyhow, with this low-dose combination, they in first-line AML had a response rate of 67% in the median overall survival of around 12 months. In relapsed refractory, it was lower as expected. And again, the data suggests that this regimen is very well tolerated, clearly less risk of extended cytopenias, and I suppose you're able to ease your dose adjust if needed if the patient is cytopenic. And the mortality was low, and the rate of neutropenic fever and bleeding was very low. So I think this is an interesting concept again in frail patients, in extremely frail patients. To summarize then, regarding my take on cytopenias is that treatment toxicity is definitely an issue with this treatment, and this may be due to the hypoplasia in the marrow, and the dosing of both azacitidine and venetoclax plays an important role. As Anne-Louise also talked about, the duration of Ven also likely plays a role. Then, of course, the disease biology matters. So my take on this is the same as the previous speakers. I would say that the dose need to be adapted depending on the clinical situation and avoid harming patients, especially patients in CR, I would say, due to toxicity. Next, I would like to comment on MRD eradication and treatment discontinuation. Anne-Louise talked a little bit about this, and I'll just again start with a brief case of a 75-year-old man with AML with NPM1 and hyperleukocytosis. He had some heart conditions, but he had just bought an apartment in southern Spain to spend his retirement. But he fell extremely ill, so he was dead sick with white blood cell count 200 and severe tumor lysis and dyspnea, and was transferred by ambulance plane to Stockholm and was diagnosed with AML, with NPM1 and TET2, so ELN low risk eventually when all the genetics came. We treated with the hydroxyurea and the steroids, and he got leukapheresis, and then we deemed him fit to start induction treatments. We got the Swedish standard 3+4 and entered CR. He did get some tumor lysis and so on, which was expected, and he actually got a pretty severe mold infection, but that was treated early and successfully, fortunately. So he proceeded with a second round of full chemo, and after this, the NPM1 MRD was 0.6% relative to diagnosis, which is, of course, very high, and he also had sepsis and pneumonia. But we, maybe right or wrong, we pushed on with the third cycle, with reduced intensity. And again, his NPM1 MRD was above 0.1%, so he clearly had not responded optimally. So he was not fit for further intensive chemo and had a suboptimal response with a high risk of relapse. So here we decided to start him on Aza-Ven maintenance, and he tolerated this very well, actually, without that many cytopenic problems, and I don't believe he was hospitalized even once during these 22 cycles. And he gradually achieved MRD negativity. As Dr. Prats alluded to, this can be slow, even in these sort of sensitive patients such as NPM1. And so it was actually after 2 years of Aza-Ven that he reached his first MRD negativity, which is quite interesting. So then he continued for another 6 months past MRD negativity, and then due to patient's wish and other things, we decided to take him off therapy. And now he's been off for exactly 2 years and is still MRD negative and is doing beautifully, normal counts. So I think this reflects to several of the things we discussed previously. So what's the data on eradication of MRD in molecular failure in AML with NPM1? Well, both we and the Danish group were part of an international collaboration where we looked at 79 patients retrospectively that had a molecular relapse or molecular persistence or progression. And just looking at all of these patients that received Aza-Ven in this setting, 71% achieved MRD negativity. And breaking this up into relapse, resistance, and progression, it differs somewhat. But as you can see, as in my patient with the MRD persistence, there was still about 2/3 that actually were able to eliminate MRD successfully. In FLT3, as expected, mutated patients tended to respond somewhat less, but again, Aza-Ven might eliminate MRD even in these patients. There was no obvious difference between HMA and low-dose cytarabine. If we look at the survival then, and this is counted from time of molecular failure. So these are patients that are deemed to have more or less imminent relapse within a year or so. And the 2-year overall survival was 67%, and it differs somewhat depending on the FLT3 ITD, especially as you can see with early relapses as expected. 44 of the 79 patients proceeded to allo transplantation, and again there are obviously a lot of bias here, and Dr. Prats alluded to the difficulty in interpreting transplant data, but just looking in this cohort, retrospective cohort, there was no apparent difference in overall or event-free survival with or without allo. So I would say in a borderline elderly patient, borderline transplantable, I would say that this argues that Aza-Ven maintenance might be an alternative here. But of course, we need prospective studies. Then what about stop studies? There are some stop studies, and I would like to just briefly touch upon this. That was one of the earliest, I believe, in AML with NPM1, treated with Aza-Ven or low-dose Aza-Ven. And all patients discontinued treatment in MRD negative remission. And due to patient's choice or physician's choice, the median number of cycles was 8, which in my view is relatively few. But still, the 2-year treatment-free remission was 88%. The data on relapse was not reported in this study, unfortunately. Another study that was recently published also looked retrospectively at all kinds of AML patients that discontinued discontinued Aza or both Aza-Ven. And these were, I will focus here on the 62 newly diagnosed patients. And 28 patients stopped both Aza-Ven, 34 patients stopped only Ven but continued Aza. And again, looking at the NPM1 mutated that were MRD negative at time of stopping treatment, the 2-year overall survival was 100%, and the treatment-free remission rate 80%. So again, this argues that in this setting, this is they actually have a relatively, actually an excellent short-term prognosis. Looking at other patients overall, the MRD negative patients versus other patients did better with regards to overall survival, not surprisingly. The patients that had been treated for 6 months or longer had, when they stopped treatment, also did better, which I think is interesting. And again, looking at if you stop Ven or both Ven Aza, so if you continue with azacitidine alone, the curves numerically are, if anything, worse. But of course, one would argue that there's no obvious difference. And again, this is retrospective. There may be many factors underlying this, but it's not so that there is a very strong indication that you should stop either or both. What happened to the patients that relapsed? Well, 11 patients relapsed and they received Aza-Ven again, but here only 3 of 11 responded, and 2 of those had IDH2, which is one of the strongest predictors, as you know, for response, and the median response duration was only 3 months. So this, of course, raises some caution. So to summarize, stopping Ven, I would say MRD negativity and treatment longer than 6 months is associated with better outcome. There's no clear benefit of continuing Aza monotherapy. We actually do this quite regularly, and of course this needs to be studied more properly, but at least data present suggest this. And if the patient relapses after stopping, the outcome is poor. So my main summary then regarding maintenance therapy with Aza-Ven is that the greatest concern is hematotoxicity, and these are relatively elderly and frail patients, and we need to dose adapt as needed, and especially in patients in CR, we should be careful to give them too much toxicity. And I would just like to stress again that data does not support at present stopping Aza-Ven unless the risks outweigh the benefit. And as I mentioned, there's a poor outcome at time of relapse after stopping therapy. An outcome may differ depending on if MRD is monitored closely and therapy is reinitiated early, but for this we need prospective study. Finally, then, I would say, at least based on now a couple of studies, that MRD negative NPM1 mutated patients that for some reason don't want to or cannot tolerate Aza-Ven, here one might consider stopping because they have an excellent outcome. But there's no general recommendation to stop, and if you stop, I would advise to continue monitoring MRD closely. All right, so this was my take on this subject, so I'm happy to take any questions. Thank you very much.
Thank you, Martin, again for a very interesting presentation. Now for the final minutes, please ask questions in the Q&A. But focusing then on NPM1 mutated AML, is it 6 months with Aza-Ven and then stop, or how do you do in your clinic?
So we actually discussed this even today at a therapy conference. In the reports I talked to, I alluded to the MRD negativity for 6 months. The treatment duration of 6 months versus shorter than 6 months was for all patients, not only NPM1. But I would say what I have tried to do now for the few patients, there are some patients that we have stopped in MRD negativity, and I try, if possible, to push 6 months of therapy, or essentially 6 cycles beyond MRD negativity before considering to stop, unless, of course, there's a substantial problem with toxicity. So that's my conservative thoughts. Maybe we could ask Dr. Prats also, if do you consider stopping routinely or only in cases with problems with toxicity or patient switch?
Yeah, it's a great question. So you summarized the data real well, Martin, and I think my practice is considering toxicity if at a year the patient really wants to get off treatment or they really can't continue on treatment. I'll do a bone marrow biopsy at 1 year. If they're MRD negative, then I'll have some confidence that stopping is acceptable. If you have real good MRD marker like NPM1 and it's negative and you're at a year, I stop those patients routinely. And I've stopped a few of the IDH patients that have had deep remissions and no markers persisting, and I've had some off for 3 years now. So it's patient-specific discussion, really.
Do we know why there are such poor outcomes once the patients relapse after treatment-free, or once they experience treatment-free relapses?
Maybe I'm not familiar with the one paper that was cited there, but I'm not sure that there's consensus on that. I think the one concern would be if they acquired some PL2 family member protein mutations. There's a handful of literature on Bax mutations, as one of the slides Martin showed. If you know the patient is that patient, then I'm, I guess, anxious about a relapse regardless. But my experience was when they relapse, they respond again. I have a handful of those that I've been off for more than a year, put them back on, and they go back in remission. So
I would say also the papers that I alluded to did not focus on that, and there was only one paper that even reported it at all, and it was only 3 patients, and that's why I added the comment on that the results might well differ if you monitor MRD closely and initiate treatment at MRD, emerging MRD. I think reasonably that might make a difference, but it would be nice actually to put together, at least retrospectively, a larger international cohort. Maybe that's something we could consider, because I mean we all have a number of patients, and it's going to be difficult to do a prospective trial.
Oh yeah,
it will take a number of years. It will take 5-10 years to.
I love the idea. So if I can participate, please reach out, because I think it is an important question. Is what the second CR2 responses durations are and whether you benefit. But that Aza-Ven paper suggests the overall survival doesn't look inferior to people continuing on continuously. So that's reassuring to me. And obviously a lot of the patients stop for toxicity. So in some respects, stopping for toxicity is the right thing in those patients.
And I think stopping for toxicity might mean that they actually are more hypersensitive, and maybe they are slightly overdosed, and i.e. that they actually got even a deeper stem cell effect. Who knows?
Right.
Great discussion. We don't have any more questions in the Q&A. Perhaps just finally, Aza-Ven as maintenance therapy after allo. What do you say?
It's a great question. It's a good thing we've enrolled completely a trial. It's called the VIALE-T trial. It was Aza-Ven given 20 milligrams of Aza 5 days per month, and Venetoclax 200 milligrams continuously, compared to best supportive care, basically expected management. It's not reported out yet. I think in the future we'll get some of that data and hopefully answer the question whether it's effective. I am doing it in some patients who are really high risk, such as those who have responded with TP53 mutations, and I need to get something in early to maintain that remission. I think the rest of the discussion on HMA maintenance post-transplant is really complicated. The meta-analysis seems to suggest there's a benefit, but a lot of the individual trials haven't shown benefits. So hopefully more to come on that. I'll be curious to hear what your practice there in the Nordic group is.
I could maybe comment at least at Karolinska, we don't give either Aza or Aza-Ven routinely as maintenance after. Of course, we might initiate it at time of MRD progression. We tend to favor sort of frequent MRD monitoring and chimerism, CD34 positive chimerism, and try to initiate treatment more preemptively rather than prophylactically. But that is just our strategy. I have no other experience.
We don't give it routinely either at Rigshospitalet, either Venetoclax HMR or just Azacitidine.
Great. Well, time flies. Do you panelists have any extra comments you would like to add, or shall we wrap it up for today?
I don't know. Do we have time? Maybe we don't have time for more questions, but I mean, maybe to Dr. Press, because it's a little bit important now, because Azacitidine will be available likely in November in Sweden, and of course it's a big discussion. But did I understand your sort of more or less standard practice to start them on Aza-Ven, but if they have IDH1, you would consider to switch them, but essentially only if they have toxicity problems, or I guess treatment failure.
That's a good summary, Martin. I don't always get the IDH status back when we start therapy on the patients. I don't wait for it. You know, the extreme age 85-year-old, maybe who's got low white count and intact platelets, then I'll suspect an IDH mutation and wait for it. But I don't, the quickness of remission, the time to remission is much quicker with Aza-Ven than Aza-Ivo. So I'll usually give one cycle of Aza-Ven, and then depending on how well it was tolerated, make a decision to move them on to Ivo-Aza or Ivo alone, sometimes even. I have a handful of people that I've done that, and I think the co-mutation status needs to be thought a lot about in these patients. Particularly the RAS and FLT3 patients do fairly poorly with conventional Aza-Ven treatments. I think they do very poorly with Aza-Ivo also, but I don't know. We've seen that data, and to me, it argues maybe in that group of patients, azacitidine-based backbone would be the best strategy, but we'll learn that, I think, with time.
Okay, thank you very much.
Yes. Other burning questions? Otherwise, I think time has run out. So then it's time for me to thank all our esteemed speakers for their presentations. And of course, we're incredibly grateful to Dr. Prats, Dr. Talbot Sørensen, and Dr. Gjersten, as well as to Nils and Christer for their valuable contributions to today's discussions and case presentations. I again want to take the opportunity to thank AbbVie for their sponsorship and the KG Jebsen Center for myeloid blood cancer for their technical support. Finally, thanks to all of our participants for engaging, submitting your quite few questions, but still. And with that, have a pleasant afternoon, and looking forward to seeing you at future events. Thank you.
Thank you very much.
Thank you.
Thank you.
So let's see, people are dropping off there. Well, thank you very much to those who are still online.
Thanks again, everyone. I really appreciate the opportunity to share and to talk to you also. Hopefully we'll cross paths in the future.
Thanks for your valuable insights and sharing your experiences. It's very appreciated, I know, from the Nordic. So
great. Have a good day.
Yeah, have a good day.
Bye-bye.
Bye. Great.